Today we are going to read about the defibrillator. It's a very important topic for the board exam also, and it's very important for our day-to-day practice also. So we made a certain objectives for today's presentation. So first we'll learn about the defibrillations. We'll review the history of defibrillations. We'll also discuss about the modern defibrillator circuit. We'll classify them, and we'll illustrate at last. We'll illustrate the use of them also. So what is defibrillation? The name itself suggests there is a D and fibrillations. D means to remove, and fibrillation is any vibration in the muscle fiber. So defibrillation is defined as the removal of the vibration in the muscle fiber is known as defibrillation. It is the term that is coined by the French neurophysiologist known as Adam Bulpain. So moving on to the history of defibrillations. So this is the first defibrillator that has been used. So it has been used on 1788 at London when the 3-year-old girl victim of the fall was shocked through the chest by an electrical generator. So this is the historical importance only. So what has happened in the first half of the 20th century in the West? As they are going to develop, there is a rapid expansion of commercially available of electrical power, but the accident also grows because of that one. So they found that the death is due to the ventricular fibrillation. So they studied how to prevent this death. So they found that if we apply the current, then we can prevent these ventricular fibrillations. Firstly, they found that when the AC is applied, it's effective in terminating ventricular fibrillations. So this is I think the Cloud and Beck's defibrillator are the first defibrillator that are used intraoperatively. This is the Beck defibrillator, and the persons who made this one. So he used this one when operating a 14-year-old boy. So there is a sudden pulse stop. So he delivered the shock, but the first shock was not successful after he administered the procaine hydrochloride. So after that, the sinus rhythm was restored. So as we know that previously AC current was used in the defibrillator, but later Russians found that the DC are more effective in the defibrillation than the AC. So here is the name of the person who invented this one. That is the Noam L. Gervis, and this is also known as a Gervis defibrillator. So this is the person who invented this. So this is the modern defibrillator, which has a pacer in it, also a ED, a manual defibrillator, and there is electrical energy also. We can choose the joule also, and we can also monitor the the cardiac rhythm also here. So let us discuss the circuits of modern defibrillators. So we are not going all of the physics, but the important physics of this one. As you know that from the defibrillator we are going to give the energy. So how this energy is calculated? It's calculated by the formula of half CV square, where C is the capacitance and V is the voltage. So this is the capacitor, whose capacitance is measured here, and this is the voltage across the capacitor. So half CV square give the energy that is delivered from this one. Let us see, when we give the AC current from our main source, it will go to the transformer, and this is the step up transformer. Will give the AC current, and there is a diode here which convert this AC into the DC. It will go through the resistance, and when it's charged, this arrow will be joined with this one. So this capacitor will be the charge. When we press the button of discharge, this energy stored will be discharged by this arrow. This arrow will go this side, so this will be discharged, and this will be go through the pedals that has been attached. So what is the main determinants of this energy joules that has been delivered? That is the transthoracic impedance. So in order to reduce this transthoracic impedance, we have to put we have to have a contact with the electrode and the skin. So we will put the some gel to have the good contact between them. So pedal of the defibrillator, as we know that we have two pedals. They have a different sizes. If it's the adult, it's a 12 to 13 centimeter, and if infants, it's a 5.8 centimeter of pedal in less than 1 year, and the pad diameter of 7 centimeter for the older children. So the size of electrode influence the transthoracic impedance. As we know that the energy delivered mainly depend upon the transthoracic impedance. So minimum recommended size is 50 centimeter squares. If we increase the size of the pedal, the transthoracic impedance will be decreases, but there is a decrease in the current density also. So they have recommended the size minimum size of 50 centimeters of the pads. So we know the size, then where to place these pedals. So they have recommended two positions, that is the anterolateral positions and the anteroposterior positions. So in the anterolateral position, pedals are placed between the ventricular apex and right infraclavicular area, and in the anteroposterior positions, the one pedal is placed over the sternum and second intrascapularly. And they have found that the anterior posterior position is more effective in the reverse of atrial fibrillation than the anterolateral positions. So, but in today's era, biphasic waveforms, the position of pedals more likely plays they play a very smaller role. So moving on to the next objectives of our presentation, to classify the defibrillators. So types of defibrillator, we can classify it as a general classification and based on the waveforms. On general classification, it has been classified as a manual external defibrillator, manual internal defibrillator, semi-automated internal defibrillator, automated external defibrillator, wearable cardiac defibrillator, implantable cardioverter or defibrillator ICD, or automatic internal cardiac defibrillator, that is AICD. Based on the waveform, it's very important for the exam, because in the board exam also they have asked for multiple times. So based on the waveforms, we can divide the defibrillator into the monophasic and the biphasic defibrillators. Monophasic has the energy of highest energy 360 joule, and the biphasic has the energy up to the 200 joules. Monophasic is again divided into the monophasic damped sinusoidal waveform MDS and monophasic truncated exponential waveform, which we will discuss later. And biphasic waveform is also divided into the biphasic truncated exponential and rectilinear biphasic wavelength. So moving on to the description of these waveforms. So defibrillator waveform, as we know that if it's a monophasic, it will have only one current delivered in only one direction, as shown in this figure. That's this direction, and it's come down. This is the only one directions. So it will go from the only one directions. But if it's a biphasic, it will go the direction in the both two directions. That is, first it's the deflection, first deflections, followed by the second deflection in the reverse directions. So this is the monophasic and the biphasic waveform. So biphasic waveform, as we described earlier, the biphasic waveform has rectilinear biphasic and biphasic truncated exponential. What is the difference between this one? As shown in the figure, the biphasic rectilinear waveform, there is a fixed current. For example, from it the current has been given up to 20 ampere. Okay, for this the current has been fixed, always fixed. This is 20 fixed current, and it's for the fixed duration. The duration time also is a fixed, for the how much milliseconds, the 4 milliseconds, 8 milliseconds, 12 milliseconds, how much is a fixed duration, and current will not change according to the transthoracic impedance. So this is the rectilinear biphasic. But in the biphasic truncated, as we seen there, the current has been increased up to 40, like 35, then it has been gradually decreases, as shown in here. Like it has in the rectilinear biphasic, it has to go straight one, the current is fixed. But here the current is decreases gradually. That's also called the truncated exponentially decreases. So it's called the biphasic truncated exponentially. And in these cases, the transthoracic impedance plays a major role. So here the current is not fixed, and the transthoracic impedance changes the current in the biphasic truncated exponential waveform. So what is the difference between monophasic and the biphasic defibrillator? Monophasic needs high energy, and monophasic leads to the more cardiac tissue damage. So in biphasic, alternated the direction of the pulse. This is in the both direction it will go. Monophasic in the single directions. So if it go in the bi direction, that there will decrease the energy level necessary for the successful defibrillations. Higher energy has to be given up to 360 joule. There is a decrease the risk of bones and myocardial damage. There is high risk in the monophasic, and there is a first success rate of VF to sinus rhythm is more than 90% in the biphasic defibrillator. In the monophasic, it's only the 60%. This is a very important topic for our board exam also. So, what determines the success of defibrillation versus time? They have given a very nice representations. The success rate of defibrillation versus time. The chance of successful defibrillation of a patient in the ventricular defibrillation decreases by 7% to 10% per minute. If there is a delay in giving the defibrillations to the patient having a ventricular fibrillation, then it decreases the chance of successful defibrillations by 7% to 10% per minute. In the after 15 minutes, there is a no survival. No one has been survived in this one. If we give earlier, there is around 100%, and it decreases like this one. So previously it was in dilemma whether to keep the shock first or the compression first if the patient with the like a VT and VF. So previously it's a dilemma, but current guidelines say that if there is a available of defibrillator, the defibrillator should be always used first before the cardiac compressions. So which will lead to the good successful defibrillations. So, what is the basic difference between the defibrillation and cardioversions? Defibrillation is the non-synchronized delivery of a shock randomly during the cardiac cycle. It has been given, it can be given in the any phases of the cardiac cycle, but cardioversion is the delivery of energy which is synchronized with the QRS complexes so as to convert an abnormal rhythm to the sinus rhythm. And the cardioversion is the electrical cardioversion or pharmacological cardioversion. Electrical cardioversions by the defibrillator, and pharmacology, there are pharmacological agents for the cardioversions. So the basic difference is shown in this figure. So this is also very important for the board exam. So in defibrillation, it's non-synchronized, it's synchronized with the QRS complex. There is if it's non-synchronized, there might be the risk of R and T phenomena which can lead to the VT-VF. It can also lead to the ventricular fibrillations. Cardioversion less likely R and T phenomena, at it is the synchronized version will keep, and can apply directly without delay. There might be the delay during synchronizations, and it's indicated in the pulseless VT and VF. It is indicated in the AF, arterial flutter, supraventricular tachycardia, and ventricular tachycardia with the pulse. So what are the energy required during this one? So energy, as we know that the defibrillator will deliver a certain energy. So all the monophasic like they have to started from the 200 joule, and it will go up to 360 joule, but biphasic they have the lower energy delivered, that's a 200 joule. So this chart will summarize the energy required. If there is a patient is the atrial fibrillations, and basically we are using the biphasic nowadays, so let us memorize the biphasic things first, and you can just go through the monophasic ones. So in the atrial fibrillation, if the patient has a AF, you can give the 120 to 200 joule, and if the patient with PSVT, then you can give 50 to 100 joule. So VT with pulse, that's a monomorphic pulse, then you can give the 100 joule, and VT with pulse, that's a polymorphic pulseless VT or BF, then you have to give 120 to 200 joule. So like you can see, if the patient is VT and it's a monomorphic VT with pulse, then you can give the 100 joule only. But if the patient is on ventricular tachycardia with pulse but the VT is polymorphic, then you have to treat it as a VF. So you have to give the 120 to 200 joules. That's the basic things. Okay, the important note is that pre-shock pause. So what is pre-shock pause? A decrease in time delay between the last compression and the delivery of a shock, that is a pre-shock pause, has received a special emphasis in 2020 guidelines, and they recommended to decrease this pause time. So if you decrease this pause time after CPR, when you are giving the defibrillation just decrease this pre-shock pause time, so it will lead to the good recovery, or the chances of defibrillation will be better. So what will happen, like if the patient is in the VF, you give the shock and you assess the patient is still in VF, then what we will do, you will do the CPR or you will do the again shock, because it's a shockable rhythm. So previously they did the compare giving the shock, after shock they give the another shock, so that is called the double sequential defibrillations. But it has not shown to improve the outcomes and increase the time to the next compression. So nowadays it has recommended, if the patient is VF, give the shock first you have to give the shock, then you have to start the compressions. So this is recommended in 2020 guidelines. So this is all about the defibrillator and defibrillation. Thank you all.